Good morning. I'm Eiji Itoi from Sendai, Japan. It's my first time to come to Qatar, so I'm very excited to be here, and I'd like to say thank you to Philip and Hakim for giving me this opportunity. So my first talk is about the bony insufficiency of the shoulder related to shoulder instability. We see quite often the bony defect of the anterior part of the glenoid and also on the posterolateral part of the humeral head. In our series, we experienced 86% with the bony defect of the glenoid and 94% of the Hill-Sachs lesion. So we want to know what the critical size is. And first, we used cadaveric shoulders, and we created a bony defect stepwise at the 430 position. That means anterior-inferior part of the glenoid. And when we created this size, the length is 21% of the entire length of the glenoid. Then, after Bankert repair, we could not restore the shoulder stability. So we thought that this was the critical size of the glenoid bony defect. On the other hand, from the clinical experience, Steve Burkhardt reported that during arthroscopic examination, he used the bare spot as a landmark, and he estimated the diameter of the inscribing circle. And when the defect is 25% or greater than this glenoid width, then the outcome of arthroscopic Bankert repair was not satisfactory. So he concluded that 25% of the glenoid width was the critical size. So from our cadaveric study, we say 21% of the glenoid length is the critical size. On the other hand, from the clinical experience, Steve Burkhardt said 25% of the glenoid width. So you may wonder which is correct. But if you compare these two sizes, we are almost talking about the same size. The shoulder dislocates into the anterior-inferior direction relative to the trunk. However, since the glenoid is inclined anteriorly, so it may not be anterior-inferior relative to the glenoid. So using 3D CT, we measure the orientation of the bony defect of the glenoid, and we found out that the orientation of the glenoid defect was almost anterior, 3 o'clock position. So in our first series, we created a bony defect at 430, but that was not correct. The exact location is 3 o'clock, so we did the study once again, creating the bony defect stepwise anteriorly. And we found that when the defect was 25% of the glenoid width, exactly what Steve Burkhardt said, that's the critical size of the glenoid bony defect. So there is a consensus about the critical size of the bony defect of the glenoid. It's 25% of this width, which is equal to almost 20% of the length. If the bony defect is larger than 25%, then we do bone graft or coracoid transfer. These days, Latarjet procedure is very commonly performed because comparing with the Bristow, in Bristow, the coracoid process is standing, and you can use only one screw. But instead, in the Latarjet procedure, you can use 2 screws, and you have a wide contact area, more stability of this coracoid process. This Latarjet procedure became popular thanks to the Didier Put's contribution. And he proposed to use 2 screws instead of one of the original procedure. And he also recommended to close the capsule with the coracoacromial ligament. And then later, Gilles Walsh recommended to use the splitting approach instead of cutting the subscapular tendon. Thanks to them, this procedure has become the standard procedure for open Latarjet. And the Didier Putt said there are 3 blocking mechanisms: bone, ligament, and muscle. So we performed this cadaveric study and find out that in the mid-range of motion, this is the stability of the intact shoulder. After creating a Bankert lesion, the stability decreased. And then we performed Latarjet, and we applied 10 Newton force, 20 Newton, 30 Newton to the conjoint tendon and the subscapularis. As the force increased, the stability increased as well. Then we removed these soft tissues, and then finally we cut the capsule. So in this study, we can say that these are the stabilities provided by the Latarjet procedure, which increased with the increase of the force to the muscles. And approximately 51 to 62% are the sling effect provided by the muscles, and the rest, 38 to 49%, are the Glenoid concavity or bone block effect. On the other hand, at the end range of the stability, these are the stabilities provided by the Latarjet, which did not change significantly with the change of the force, and about 76% of them are provided by the sling effect, and the rest, 24%, by the capsular effect. The interesting thing about the Latarjet is this. After performing Latarjet, the stability is even greater than the intact shoulder. Because of this extra stability, some surgeons prefer to use Latarjet for high-risk patients like a rugby player. This is a report from Jill Walsh's group. They performed Latarjet procedure in 37 shoulders, all rugby players. They followed up for 12 years, and all but one returned to rugby, no recurrent dislocation. It's an amazing result. And the remnant apprehension in 5. X-ray shows mild osteoarthritis in 30%, which is not significantly different from the background osteoarthritis prevalence. Now let's go to the Hill-Sachs lesion, which is the compression fracture of the humeral head created by the anterior rim of the glenoid. If there is a bony defect of the glenoid, but you perform the Bankert repair, then at the end range of motion, the shoulder is stable because the anterior capsule is tight. So if there is a bony defect, it doesn't matter at the end range of motion. However, if you bring the arm to the mid-range, then the anterior capsule becomes lax, and then the head starts to slip out of the socket because the socket is shallow due to the bony defect. So the glenoid defect is related to the mid-range instability, not to the end-range stability. On the other hand, Hill-Sachs lesion has nothing to do with the mid-range instability. But at the end range, if the Hill-Sachs lesion is covered by the glenoid, it is safe. However, if the Hill-Sachs lesion is greater than the width of the glenoid, then it engages and another dislocation occurs. So the Hill-Sachs lesion is related to the end range instability. So this is an important concept I would like you to remember. The glenoid defect is related to mid-range instability, whereas a Hill-Sachs lesion is related to end-range instability. The tricky thing about Hill-Sachs lesion is this. Take a look at this. This Hill-Sachs lesion is totally safe because it's entirely covered by the glenoid at the end range. So there's not a chance that this Hill-Sachs engages with the glenoid rim. However, the same Hill-Sachs lesion is not safe anymore if there is a bony defect of the glenoid. Then the same Hill-Sachs lesion engages and causes another dislocation. So it's not the absolute size of the Hill-Sachs lesion, but the relative size of the lesion to the glenoid that matters. All the previous investigators measured the size of the Hill-Sachs lesion, area, depth, volume, but none of them pay attention to the relative size of the Hill-Sachs lesion to the glenoid. So for this purpose, we introduced a new concept called glenoid track, which means the area of the humeral head covered by the glenoid with the arm along the posterior end range of motion like this. So if the Hill-Sachs lesion stays within this track, it's safe. So first we use cadaveric shoulders and we move the arm into maximum external rotation and horizontal extension and elevated the arm from 0, 30, up to 60. 60 means 90 degrees of abduction to the trunk. As you see here, the glenoid shifted from inferior-medial to superlateral direction along the posterior margin of the articular surface of the humerus, creating a zone of contact. We call this zone the glenoid tract. If the Hill-Sachs lesion stays within this tract, there is not a single chance that the anterior rim of the glenoid engages with this lesion, so it is totally safe. However, if the Hill-Sachs lesion extends more medially, then there is a chance of engagement and dislocation at this point. The glenoid tract is created by the glenoid itself, so when the glenoid is intact, it's the widest. If there is a bony defect of the glenoid, then the glenoid tract becomes narrow. So we want to know where this medial margin of the glenoid tract is. First, we measure the width of the glenoid. It's 100%. Then the medial margin of the glenoid tract is located at 84% from the medial margin of the footprint of the rotator cuff. If there is a bony defect like this, then we subtract this width to obtain the true glenoid tract. Next, we wanted to measure the glenoid tract in live shoulders. So we bring the arm to maximum external rotation and maximum horizontal extension, and then we move the arm up and down along the posterior margin of the end range. Next, we took a MRI and we created this 3D skeletal model. And as you see, the scapular moves and also humerus moves. And eventually, we fix the humerus and let the glenoid move on the humeral head. So this is the true glenoid tract observed in live shoulders. As we saw in cadavers, the glenoid moved along the posterior margin of the articular surface of the humerus, creating a zone of contact. So using this method, we measured the glenoid tract width in live shoulders, which was 83% with the arm at 90 degrees of abduction, which is very close to the cadaveric measurement, and it's a little narrower superiorly and a little wider inferiorly. So what is an engaging Hill-Sachs lesion? During arthroscopic examination, you perform this abduction external rotation, and this Hill-Sachs lesion engages with the glenoid rim. So you say, oh, this is an engaging Hill-Sachs lesion. We need to do the remplissage. But that is not correct. By definition, the engaging Hill-Sachs lesion is this: the Hill-Sachs lesion that engages with the glenoid after Bankart repair. Because before Bankart repair, all the Hill-Sachs lesion engages with the glenoid. That's why the patient needs surgical stabilization. And almost all the previous papers, they do the dynamic examination before Bankart repair, and as a result, the prevalence of engaging Hill-Sachs lesion is 34 to even 46%. Definitely, this is an overdiagnosis of engagement, and it should be evaluated after Bankart repair. We found only one study from Younger Lee's group. They performed this dynamic examination after Bankart repair, and they found 70 shoulders engagement. That's 7.1%, and they performed remplissage. But using this technique, there is a risk of repair failure. You repair the Bankart, but if you do this, you may break the repair. So in order to avoid that, we recommend this second definition. When the Hill-Sachs lesion is wider than the glenoid tract, then that's a true engaging Hill-Sachs lesion. But the word engaging is confusing because this Hill-Sachs lesion truly engages with the glenoid rim. That's true. But this is not the engaging Hill-Sachs lesion by definition. So it's very confusing. So we propose a new concept, new terminology. This is the Hill-Sachs lesion, the medial margin of the footprint, and this is the 83% of the intact glenoid. So in this case, the Hill-Sachs lesion stays within the glenoid tract. So this Hill-Sachs lesion is on the glenoid tract, so we call it on-track Hill-Sachs lesion. On the other hand, this is a large Hill-Sachs lesion, and also there is a bony defect of the glenoid. So in this case, we measure the intact glenoid first, and this is 83% of the intact glenoid. And then we measure this defect width, and we subtract this defect width. This is the true glenoid tract width. So in this case, the Hill-Sachs lesion is out of this glenoid tract. So it's off-track Hill-Sachs lesion. On track, off track. This will be published soon in Journal of Arthroscopy. So using this glenoid tract concept, we found that in our series of 100 cases, there are 7% of off-track Hill-Sachs lesion, exactly the same as younger Lee's report. So it's not 30%, 40%. Engaging Hill-Sachs lesion or off-track Hill-Sachs lesion is just 7%. There are two methods to fix it. One is bone graft, one is remplissage. If you perform bone graft, then the glenoid can move over this grafted bone. So there is no limitation in the range of motion, no problem. However, if you perform remplissage, then the infraspinatus tendon fills this defect, so when you try to move your arm along the posterior margin of the end range, the glenoid cannot ride over this area. It moves around this area. So there is definitely a limited range of motion if you perform remplissage. That's something you need to consider. We performed this cadaveric study, which will soon be published in Arthroscopy, and we used cadaveric shoulders, and we measured the horizontal extension, which was significantly decreased if we create a large Hill-Sachs lesion. Also, the external rotation with the arm in abduction is significantly decreased if you do the remplissage. In the previous, cadaveric shoulders show that there is 5 to 10, 15 degrees of limitation in external rotation, and also clinical data show that around 10 degrees of limitation in external rotation. This may be acceptable for the ordinary people, but this is definitely not acceptable for throwing athletes. So for the throwers, you must consider whether to apply this or not. So the treatment option is this. For the on-track Hill-Sachs lesion, you don't have to worry about Hill-Sachs, and the glenoid defect is small, just fix the soft tissue. That's enough. For on-track Hill-Sachs lesion and the glenoid defect is greater than 25%, you have to fix the glenoid, for example, by Latarjet. For the off-track Hill-Sachs lesion, if the glenoid defect is small, you have to think about this Hill-Sachs lesion. So the remplissage may be the best indication, but if the patient is a throwing athlete, you don't want to do the remplissage. Or the patient is a high-risk group, like a rugby player, then you may want to do the Latarjet procedure. That's fine. Because if you do Latarjet, that will convert off-track Hill-Sachs lesion to on-track Hill-Sachs lesion. For the off-track Hill-Sachs lesion, the large glenoid defect, you always have to fix the glenoid first. And almost always, if you do Latarjet, that will convert off-track to on-track. So you don't have to worry about Hill-Sachs lesion anymore. But theoretically, after the Latarjet, if it's still off-track, then you add a remplissage. So in summary of my lecture, there is a critical size of the bony defect for the glenoid. If it is larger than 25% of the glenoid width, this is a critical defect. You have to do something. And for the Hill-Sachs lesion, if it is wider than the glenoid tract, then it is a critical size. We call it off-track Hill-Sachs lesion. It used to be called engaging Hill-Sachs lesion, but as I said, it's a very confusing terminology. So we propose to use off-track Hill-Sachs lesion. For the off-track Hill-Sachs lesion, if the glenoid defect is large, fix the glenoid. If the glenoid defect is small, you can do either remplissage or Latarjet, either one or the other. But for the throwing athletes or high-risk patient, you have to be careful to perform remplissage. I'd like to thank my co-authors. Thank you for your attention.